Okay. Good evening, everyone. Thanks for joining me this evening. My name is Charlie Lees. I am a consultant gastroenterologist in the Edinburgh IBD unit, and I am Professor of Gastroenterology at the university. I want to spend some time this evening, I think, on a very timely topic, and that is talking about COVID and immune-mediated diseases, particularly to try and answer the question of whether or not the vaccines work in immunosuppressed patients, or rather how well they work, and to start to have some conversation around what we can do about that. Now, inflammatory bowel disease is my area of expertise, and inflammatory bowel disease, Crohn's disease and ulcerative colitis, they are archetypal immune-mediated inflammatory diseases, or IMIDs. And so I'm going to talk about this in the context of IBD, but with, I think, broad implications for all immunosuppressed patients. So these are my disclosures. My funding comes from UK Research and Innovation, and here are some of my conflicts of interest. I started writing this talk a week ago, and gosh, a week is a long time in COVID. A week ago, this is what the graphs of cases were looking like from the R World in data. And of course, we had this big spike in cases because of the Delta variant in the United Kingdom. And at this point, it was near vertical, it was going up, and we did not know where it was going to end. Was it going to be 100,000 cases, 200,000 cases? What was going to happen? Not just in the United Kingdom, we saw the big spikes already starting to happen in the Netherlands, in Spain, in Portugal, France, things turning the corner for the worse in the United States, and some standouts looking at Fiji and Cyprus. On Monday, I revisited the slide deck and I updated the graphs. And thankfully, we see that things have turned the corner. And of course, this has been the news item of great interest in the last few days. Why is this happening? Is it happening now because of vaccines? Is it happening because we're reaching some kind of herd immunity? Are we now in a more favorable position in the United Kingdom because of schools closing in England? Is there an effect on the Euros? Probably. Is it because the weather's been nicer and people have been outdoors? The expert consensus from reading around in the last couple of days seems to be it probably is a mixture of all of those things, but no doubt vaccines have a huge part to play, and I'll show in a few slides' time how we are in really a very privileged position in the developed world, particularly in countries like the United Kingdom, with a great vaccine rollout compared to other parts of the world. Because COVID has been very uneven, this is now cumulative COVID deaths, and we can see South America as a standout here, the United States, of course, India, and United Kingdom heading these European countries here. And if we plot this out on a map of the world, we can see really this uneven global distribution. And this is where we know that these are COVID deaths. In other parts of the world, we will be undercounting significantly. So the challenge is not just to vaccinate ourselves, it's to vaccinate all of the world. And whilst we have had a really tremendous rollout in the United Kingdom, following the example set by Israel and also in the United States, it is, of course, very pleasing to see many other countries catching up with us now across Europe, looking at the amazing rollout in Canada and other countries. But you can look down the bottom here and you can see how the world is getting on at vaccinating itself. And actually, there is a long, long way to go. This is the sort of league table, if you want, looking at those in the totality of the bars going across from left to right that have had at least one dose of vaccine, with the darker green showing those that are fully vaccinated with 2 doses of a COVID vaccine. You can see Canada, the United Kingdom, Spain, Italy, Germany, France, USA. But when you get down and down and down, you can see that the percentages are very low indeed when we get to low and lower middle income countries, where many have not even managed to vaccinate their most vulnerable people, nor even their healthcare workers. And very strikingly, if you actually plot this out by income status amongst countries, boy, it starts to look uneven. High income, upper middle income, low middle income, and low income countries with just a tiny slice of what's going on globally. Does this matter? Yes, it does. And we should care about this, of course. If you look at this incredible infographic produced by John Van Murdoch for the Financial Times, you can look and see how uneven this has been. This looks at the pandemic in total, and you can see for each country the top area of the graph, which is in light blue, which is cases, and the bottom area of the graph in red, which are deaths. And you can see on the top left, the United Kingdom, where cases and deaths mirror one another with the first and second waves. But in this third wave, you can see how with the most vulnerable people vaccinated, the mortality is much lower. So we can see that for the UK and Portugal. But when you look on the right to Namibia, Tunisia, and South Africa, you see a very different story when the latest wave, where the Delta variant is being hyper-transmissible, we see unfortunately still very high cases of mortality mirroring the wave. It's very more, even more stark if you just zoom in onto the last 2 or 3 months here. Same graphs, but just looking at the most recent time point. So here, UK and Portugal with really negligible mortality and compared to what we've seen with the case increase compared to this now very sort of almost terrifying mirror image in Namibia, Tunisia, South Africa, Georgia, Malaysia, Russia, Indonesia, and Zimbabwe, as seen here. You compare this second and third wave in a bit more detail in the United Kingdom. And this looks at the days of each wave. So this is day 1, day 5, day 10, up to day 50 of the second wave, where you can see cases per 100,000 population on the left in the red here, and you see the deaths start to creep up. And so by the time you get to the end, these bars are about the same. But over the same time period of the third wave, we're not seeing the mortality increasing at anywhere near the same. The link between cases and hospitalizations and deaths has not been cut completely, but it has been quite significantly severed. This is Scottish data now, and this is looking at cases in the green, hospitalizations in the orange, and ITU admissions in the red, which of course is the smallest. And you can see for first and second waves, you can see very neatly how the hospitalizations slightly lag behind the cases. And okay, we do see cases transmitting to hospitalizations in this latest wave, but it's not the same as what we saw before. And if you look very recently, this is from 2 or 3 days ago now, looking at the 7-day rolling averages in Scotland, in the blue, we're looking at cases, and in the red now hospitalizations. So we've seen in Scotland the cases start to decrease already for about 3 weeks. From a position 4 weeks ago when I was on summer holiday, the first week of the Scottish school holidays, where we had the highest rates of COVID in the whole of Europe, in Tayside and in Edinburgh, across all the counties. Since the schools broke up, since Scotland were knocked out of the Euros, we've seen that decrease, and this is now transmitted to hospital admissions. I've not shown it here today, but in NHS Lothian, we get daily a dashboard with what's happening with hospitalizations. There are still patients being admitted, but the median age has dropped from about 80 at the start of the pandemic, settled to about 70, 75 during the second wave. It's now in the low to mid 40s. And along with that, the average duration of stay has tumbled. So people are now typically in for 2 or 3 days, whereas previously they were in, of course, for much longer. And unfortunately, many of those patients were going into the intensive care unit, and many were dying. And this is because of vaccination. It's because we vaccinated the right people. And again, credit to this, I think, very neat infographic from John Byrne Murdoch at the Financial Times. And what you can see here is divided up by age band. So we're going from age 30 to age 90 here. And in the red, we're showing you the mortality, the case fatality rate of a COVID infection pre-vaccine. And we're going down to the blue arrow post-vaccine. And note that this is a logarithmic scale, so this is a 1% mortality, so you can see that 80-year-olds had a 1% mortality previously, but now after vaccination, that's dropping down to less than 1 in 1,000, and that's equivalent to a 50-year-old person prior to vaccine. So the vaccination has taken the risk of mortality for an 80-year-old, and we know just how terrifying the mortality rates were for these older people in the first and second waves to that of a 50-year-old now. Quite substantial. And if you look at what's happening to younger people, 30, so let's just take, I'm 45, let's take a 45-year-old. The risk has gone from somewhere in the region of 1 in 5,000 down to 1 in 100,000 after vaccination. One of the things that we're seeing in the news a lot is that actually people post-vaccination are still getting admitted to hospital, and people are starting to say, well, gosh, does that mean the vaccines aren't working? Well, quite the contrary, and actually without going through this in any great detail, there's an interesting exercise we can look at here. So let's just go to the beginning of the pandemic, where no one was vaccinated. Then we could say 100% of the hospitalizations were in the unvaccinated population. And let's just say to the other extreme now, we'd vaccinated everyone and we had 100% of people vaccinated. Well, we would now be able to say that 100% of hospitalizations were in the vaccinated people. So you can do some maths to show what happens if you have a population on the left that's 92% fully vaccinated, or on the right 70% vaccinated, and you can show what that means in terms of the number of people who are in hospital, or the percentage that are vaccinated versus that are not. The overall numbers are less, but the percentage is higher. So actually, a higher percentage of people in hospital who are vaccinated is actually a marker of a successful vaccine rollout. And we in the UK have a very successful vaccine rollout. This is looking at people who are fully vaccinated, having had 2 doses of vaccine split by age. We can see we're well in excess of 90% for those aged 70 and over, 75 and over, 80 and over, also 65 and over. It drops to 80% when you get to this bar here. So this is 50 and over, and you can see how the younger age groups are catching up. Ideally, we get everyone fully vaccinated. But the thing that I think we have done so very, very well is that we have vaccinated the vulnerable people. We vaccinated by age. And what's not shown here is we vaccinated by comorbidity. And that means for us, in gastroenterology, looking after patients with inflammatory bowel disease, that our high-risk patients are patients with steroid therapy, our patients on immunosuppressant therapy, our patients requirement on drip feeding, our patients with active disease have been fully vaccinated early in the pandemic and by and large are protected. But the question is, how well protected are they? And what I'm now going to do is switch gears a bit to talk about a patient of mine who comes in the midst of the pandemic with a series of questions. So here we have a 45-year-old man, very classic case, works as a teacher. He has ileocolonic Crohn's disease. So Crohn's disease affects the large bowel and the small bowel. He's had it for a couple of years. And as is very typical now, he's been managed with a top-down therapeutic approach with an anti-TNF-based strategy using Infliximab as a biosimilar with azathioprine to protect against anti-Infliximab antibodies. And he's got very well-controlled disease. And we want to keep it that way so that he stays well, so that he stays out of hospital, so that we don't need to use steroids, and particularly important for those factors during a pandemic. He has a little bit of comorbidity. He's slightly overweight. Actually, his blood pressure is a little bit high, but otherwise he is fine. He does wonder if he had COVID in March because he had symptoms that were typical of that, but this was very early days in the pandemic, so he did not have a PCR test. So he comes later on with a few questions. He wonders, is he at risk overall of getting the virus or of getting severe disease with COVID? What he should do about his medications? Should he have the vaccine? If so, which one? Will the vaccine work as well? And that's the key question we're going to address today. And what about the risk of reinfection? So let's think about these first couple of questions and let's just remind ourselves the key things we've learned about risk with COVID. We've learned that it is older people and more male orientated, the people at risk of severe COVID outcomes. That's typically intensive care admission and or death. More than just age, which you can see separates by band the older you get, and sex. We know obesity is an adverse risk factor. We know that non-white ethnicity and social deprivation are also significant risk factors. More relevant to us are comorbidities. So we have a history of previous cancer, in particular hematological malignancy. We have kidney disease. We have chronic chest and heart disease and liver disease and neurological disease. We have solid organ transplant. And then at the bottom here, we have other immune suppressive condition and rheumatoid arthritis. This is from the Open Safely dataset in England across 17 million records in primary care. We have gone back into the Open Safely with a consortium of IMIDs. So we've gone from the rheumatologists with the dermatologists and myself and Nick Kennedy from the gastroenterologists to look across inflammatory joint, skin and bowel disease to look at the risk of severe COVID. And we'll be publishing these data imminently. The bottom line being is that it looks like there is a very slight increased risk of adverse outcomes across the IMIDs, but it doesn't look to be too significant. It looks to be most in inflammatory joint disease when you control for other factors, and in fact lowest in inflammatory skin and inflammatory bowel disease. But we did not know that at the start of the pandemic. So we convened a working group to try and best guide our patients and our organizations about the risk of adverse COVID outcomes with inflammatory bowel disease. This aligned very closely with what our rheumatology and dermatology colleagues were doing, with the aims to keep our patients well, safe, and out of hospital. I was very proud of the efforts, particularly that we put in place locally in the Edinburgh IBD unit to maintain our team, to keep a regular service with our helplines working, both to gain direct patient communications as well as with our colleagues in primary care. We virtualized our working. I established a daily huddle for the IBD team in the mornings and a daily flare clinic where we've been seeing a couple of patients every day. With the consultant of the week running that service now embedded into our weekly plan of work, so that people who look at high risk of coming into hospital but don't obviously immediately need to come to the flare clinic, and we can then see them, counsel them, start them on therapy in an expedient manner and keep them out of hospital. And this has worked really very well for us, as has keeping our infusion suite maintained throughout, despite having to move it twice, so we can keep our patients going with their critical biologic medicines. I won't go into risk in too much detail because this is slightly past the point now, but I think we got it by and large right. This is the IBD risk grid. The rheumatologists and dermatologists had similar ones. We mostly looked at risk based on age and comorbidities. We also looked at patients who are on corticosteroids and other high-risk phenotypes such as short gut syndrome requiring nutritional support, or moderate to severely active disease that was uncontrolled on therapy. Most of our patients stable on biologic therapy were in the moderate risk group, so this was equating to JCVI group 6. And with the rest, for example, you see patients stable on mesalazine, just the same as the background population. So let's move on to vaccines, because that's the important topic now. Patient asks, should I have the vaccine? Well, absolutely the patient should have the vaccine. I'll just very briefly remind ourselves that we have adenovirus vector and mRNA vaccines, all geared against the spike protein. These are still the 6 vaccines that have published evidence of effectiveness, and all have been shown to prevent severe COVID and death, and they have all been shown to do that against all of the variants, including Delta, which I think is a really important point. And we shouldn't forget, I don't think, in the mix of all of what's happened, just how significant and triumphant a success the vaccine development is. I love this graph from Our World in Data showing how open-ended the search for a vaccine remains for diseases like malaria and tuberculosis, despite well over a century of exploration. The open and shut cases just that took a while, like whooping cough and polio and measles. More recent exercises that are still ongoing, like HIV. But COVID-19 packed very neatly into this very short phase of extraordinary discovery. Vaccine development that was taken at risk of financial cost by the pharmaceutical industry and by governments, not at risk of safety. And that's a really important thing we keep reminding ourselves. So for inflammatory bowel disease, we had 2 sets of guidance that we are still using that say more or less the same thing. And I've just distilled the key points because I think it's worth reiterating those today. This is the guidance published by the International Organization of IBD and Gut, which very simply stated that patients with IBD should be vaccinated against COVID at the earliest opportunity to do so, and do not defer vaccination because a patient is on immunosuppressants, nor should you defer immunosuppressants for a patient to get vaccinated. And I think by and large, despite what I'm going to show you, that is the correct approach. The BSG and Crohn's and colitis, we put together some guidance. This was led by Nick Powell at Imperial, strongly advocating for COVID-19 vaccination for patients with IBD. The risk of COVID vaccination in patients with IBD anticipated to be very low, with the key concern in patients taking immunosuppressant drugs being the theoretical risk of suboptimal vaccine responses, which I will come to. So he asks, which vaccine should I have? Well, the very clear spoiler is you should have whichever one you are offered, and we still think this is correct based on all the data that we have amassed to date. So be that the Pfizer-BioNTech mRNA vaccine that showed the staggering effectiveness. We need not forget this was the first vaccine to show effectiveness, nor the mRNA 1273, the Moderna mRNA vaccine, or the Oxford AstraZeneca vaccine. These vaccines all shown to be effective against wild type, but most recently we've wondered how well do they work in the real world, the vaccine effectiveness against Delta. And now we know this. This is a publication from about 3 weeks ago now in the New England Journal of Medicine from Public Health England, who have really produced some staggeringly good data, which they have shared in a rapid manner throughout the pandemic. What we have here is data on vaccine effectiveness for the Alpha or Kent variant and the Delta variant, originally described in India, when patients vaccinated with Pfizer-BioNTech and with Oxford AstraZeneca with 1 dose and with 2 doses. So we'll look first at the left-hand set of graphs, and you can see this is after 1 dose. So you can see Pfizer-BioNTech and Oxford AstraZeneca with both the Alpha and in particular with the Delta variant in the purple, that the vaccine's working not brilliantly, But after 2 doses, the vaccine effectiveness is very good indeed, especially with Pfizer-BioNTech, but also really with the Oxford-AstraZeneca vaccine, where you see a decrease with Delta compared to Alpha, but that decrease is relatively modest. So when patients, and this is all people, this isn't patients, this is all people, are vaccinated against COVID with either Oxford-AstraZeneca or with Pfizer, and note that this is with the JCVI schedule. So this is with many of these patients with a 12-week gap between doses, some down to an 8-week gap. We see excellent vaccine effectiveness. That's interesting because the Israeli vaccine effectiveness data actually, and this is all with Pfizer-BioNTech, shows much lower vaccine effectiveness with 2 doses of the Pfizer-BioNTech. And that probably is 2 things. Firstly, there is some waning of the antibody responses over time. So vaccine effectiveness is shown to be lower in the latest wave in those people that were vaccinated earliest, right back in December, January. But also, it looks like that longer gap between dose 1 and dose 2 of vaccine that we already knew was better for the Oxford-AstraZeneca vaccine is also better in inducing more robust serological responses with Pfizer-BioNTech, with 8 weeks looking to be the sweet spot there. So let's just look at the immunosuppressant question now. He asks, will the vaccine work as well? I'm on azathioprine and Infliximab. And of course, this is a very good question. We know with other vaccines for other infections, other viruses and bacteria, that patients on immunosuppressant medications, including anti-TNF drugs and including thiopurine, such as azathioprine and captoprine, that the serological response is less robust. So we've seen that for H1N1, for hepatitis B, for pneumococcus, for example, to name a few that you can see on this chart here. So we wanted to study the effect of the vaccine on our patients with inflammatory bowel disease on immunosuppressants to help address this question, not just for our patients, but for all immunosuppressant patients. This is the CLARITY study, which I'm going to dive into in a bit now. CLARITY was the brainchild of Tariq Ahmed, a good friend down in Exeter, and Nick Powell in London, along with Nick Kennedy, who trained with me in Edinburgh, and Claire Bouchy, who was the key project manager. And what we did was we set up 92 sites across England, Scotland, and Wales, and recruited 7,000 people with inflammatory bowel disease on Infliximab and vedolizumab in the 10 weeks leading up to Christmas. Incredibly proud of the effort we did in Edinburgh, thanks to Loran Derricks, my IBD research fellow, and Kate Koval, our IBD research nurse extraordinaire. Out of the 92 sites, we were the 3rd highest recruiting site here, recruiting 243 patients. This here shows you the recruitment in those 10 weeks leading up to Christmas. Now, the key thing we were doing here was looking at the effect of Infliximab, a key anti-TNF therapy like adalimumab, and we were looking at the effect of that on response to infection with COVID and response to vaccines against COVID. So we had 2 Infliximab patients, and as a control group, we looked at vedolizumab. Vedolizumab is a drug we use now a lot for ulcerative colitis, but also for Crohn's disease. It is an anti-integrin monoclonal antibody that is gut-specific. So it targets the trafficking of white blood cells from the periphery to the gut, and then works very well to calm down the inflammatory process in IBD. It doesn't interfere with systemic immune responses, so it's a great control, but it's also given by an IV infusion. So our infusion suite is giving patients 8 weekly infusions of Infliximab or vedolizumab. So vedolizumab was an excellent control group for Infliximab to look and study. So having recruited all of these patients, the first question we asked was, had they had similar COVID experiences? So we looked and we saw that they had adhered to social distancing measures in a comparable manner between the two groups, as was exposure to COVID-19 cases. And we didn't see any differences between Infliximab and vedolizumab in patients who reported symptoms of suspected COVID-19, who tested positive by PCR, or those who were hospitalized with confirmed COVID-19. When we looked at the serology, we could see that there were different rates of COVID infection across the UK. So this is the last quarter of 2020 that we recruited patients. So as we would have expected then, the serological rates were lower in Scotland, as well as in the southwest and Wales, but highest in the Midlands, the northwest, and in London. Most interestingly, we saw that the serological response was lower in Infliximab versus vedolizumab. So this is looking at the anti-nuclear capsid antibody to the SARS-CoV-2 virus. So this tells us if someone has immune memory to having had the infection, and we could see that despite having the same number of cases by PCR and by hospitalization, we could see that there were lower rates in Infliximab versus vedolizumab. Moreover, when we divided them by those patients who were on Infliximab therapy by itself, or those who were on Infliximab plus an immune modulator, we could see a different effect. So Infliximab with azathioprine, 3% had antibodies. Infliximab without azathioprine, it's 4%. Vedolizumab with azathioprine, it's 4.5%, and vedolizumab by itself, it was 6%. So we're seeing a clear impact or attenuated serological response to SARS-CoV-2 infection in people on Infliximab, and moreover those in Infliximab plus azathioprine. So we looked at the factors that were associated with having antibodies to COVID. We saw non-white ethnicity, as you would expect. We saw geographical location, as I've shown you. We saw non-adherence to social distancing, as you would expect. And we saw that people who were on Infliximab and those on azathioprine had lower rates of antibodies. So flipping this around, we then said, if you've had COVID, how likely were you to seroconvert or have antibodies against COVID? And overall, if you looked at the vedolizumab patients, it's 80%, so that's what we'd expect in the healthy population. Overall in Infliximab, it's about 50%, and if you're on Infliximab and azathioprine, that drops to 37%. So in this first phase of CLARITY, we saw that patients on Infliximab were no more likely to get COVID or have severe outcomes, and after COVID infection, they had reduced antibodies. So we were saying to patients, please keep taking your medicines. They're most important to keep you well, to keep you out of hospital, to avoid you having a flare that needs steroids, etc. But the key question was, how does this translate to the response to COVID vaccination? So this was the next phase of the study where we asked, what is the impact of Infliximab on the immune response to COVID-19 vaccination? And to do this part of the study, we need a different antibody ELISA. Here we need to look at the anti-SARS-CoV-2 spike antibody. So that tells you if someone has been vaccinated and has a serological response to the vaccine. And here in this first cut of the data that we published in Gut a couple of months ago, we had 800 patients on Infliximab and 400 on vedolizumab, about 50-50 with Pfizer-BioNTech, 50-50 with Oxford AstraZeneca with the different drugs. And at this stage, most of the patients were in the middle of that 12-week gap, so they had only had one dose of vaccine. And what we could see, very interestingly, was that after one dose of vaccine, the patients on vedolizumab in the orange here, with either Pfizer-BioNTech in the left-hand panel or with Oxford AstraZeneca in the right-hand panel, had good serological responses that correlated to this green line, a titer of about 15 nanomole that said that they were looking like having protection already. Whereas those people on Infliximab after one dose didn't have obvious protection against COVID infection. So we looked at the factors associated with spike antibody concentration. We could see Infliximab, we could see azathioprine. Here we saw Crohn's disease being an effect, older age, current smokers, and interestingly, non-white ethnicity was associated with higher anti-spike antibodies. Looking again to look at the percentage of the patients that develop protective antibodies against COVID, you can see how neatly this separates out. When you look at the left-hand side, Infliximab plus azathioprine, only 27% had protective antibodies against COVID after one dose of vaccine. Infliximab by itself, 36%. Vedolizumab plus azathioprine, 55%. Vedolizumab plus vedolizumab by itself, 75%. That was with Pfizer-BioNTech, and you could see a similar trend with Oxford AstraZeneca. So, with the UK JCVI recommendation of 12 weeks between dose 1 and 2, the message clearly at this point was, if you're on Infliximab or Infliximab and azathioprine, and by proxy probably also adalimumab and azathioprine by itself, then you have less protection against COVID infection if after one dose of vaccine. But importantly, after 2 exposures, things got much better. So here we can see, and this is an early cut of the data, we have a later cut of this data that shows this even more robustly. If you have had prior infection and 1 dose of vaccine, you are good, even if you're on Infliximab. And if you have 2 doses of either vaccine, your antibody levels are good, even if you're on Infliximab. So the message here is patients on Infliximab have, after 1 dose of either vaccine, have lower levels of protective antibodies to COVID. Patients on Infliximab had normal levels of protective antibodies if they've had COVID already and had 1 shot of vaccine, or if they've had 2 doses of vaccine. So what medicines are affected? Well, we've looked here at Infliximab and Infliximab plus azathioprine, but we expect this applies to all anti-TNF drugs. And whilst we did not study it directly, we suspect this applies to patients taking azathioprine, mercaptopurine, or methotrexate alone. And we expect this doesn't just apply to IBD, but also applies to those with inflammatory joint and inflammatory skin disease. We put out a message of reassurance to patients saying, please don't be worried, please keep taking your medicines, please get vaccinated at the earliest possible opportunity. And I'm really pleased that vaccine uptake in our patient population has been extremely high. We advise patients to continually social distance after the first dose of vaccine. And a while ago, we were saying to everyone, please get the second dose as soon as you can. Thankfully, almost everyone has now had their second dose of vaccine. The next question is, should they have a booster? We have new data that we have just submitted for publication that strongly suggests that our patients should have a booster. So we'll be looking for all our patients, and that's the IBD patients and all the IMID patients in groups 4 and 6 to be getting a booster shot of vaccine along with that program in the autumn. What about the other drugs? Well, we've just set up in Edinburgh to recruit to the VIP study, which is a follow-on from CLARITY that Nick Powell's leading, where we're looking at patients not just on Infliximab and vedolizumab to get more data on those, but also looking at patients on azathioprine and mercaptopurine by themselves, also looking at tofacitinib, a JAK inhibitor that we use for ulcerative colitis, and of course the rheumatologists use a lot. Also to look at ustekinumab or Stelara, an anti-IL-12 antibody that we use for Crohn's disease and ulcerative colitis. We have about 200 patients on that drug in Edinburgh, also used, of course, by the rheumatologists and patients on combination therapy too. So we're recruiting those patients right now. The risk of reinfection depends, I think, on how well the antibody responses hold up, how quickly they decrease over time. and it looks like they probably do decrease quicker over time in patients on immunosuppressant medications, highlighting the need for a booster. So that's pretty much it. I think what we've seen is that we have got reassuring messages for our patients that there is no major increased risk of severe outcomes with COVID. The one exception to that is probably rituximab, which looks to be associated with an increased risk of severe COVID. We don't use that in IBD, but of course that's relevant to the rheumatologists. Anti-TNF drugs, I mean, I've shown you about those here. In fact, they look, if anything, to have a protective effect against severe COVID. Corticosteroids, there is a question about still. There are several data sets that show they're increased with worsening COVID outcomes. They probably also impair response to vaccines. We are very mindful not to overprescribe corticosteroids with prednisolone. And actually, we prefer to treat our patients with effective therapy with biologics where we can. I wrote this slide about collateral damage from COVID way back in May 2020. I haven't changed it at all since then. Clearly, we're still in the long-term outcomes here. For us in gastroenterology, this means backlogs for scopes. Actually, I think Colin and team have done a great job keeping the service going in Edinburgh and elsewhere. But we do have a backlog for investigation surveillance for IBD patients as a result. Surgery, of course, is still impacted. With cancer prioritized, that means it can be harder for IBD patients. Despite our best efforts to keep our clinics going, some of our patients haven't been seen and they have had disease that's progressed, and we're catching up from that. And of course, across the piece, levels of fatigue amongst not just our patients who've had, some had very difficult pandemics with long periods shielding and isolated, significant mental health issues and burnout, but also, of course, amongst staff too. So I always like to remind ourselves that the reality is probably not as bad as how we imagine it will be. I'm hoping that the reality of the next period of time is going to be very bright. The latest data, I think, are optimistic indeed. And with the booster program, I think our patients will be well protected moving forwards, and that has been my priority throughout. Of course, we don't quite know where things are going next, but I think we're much closer to that. We've been very careful to try and collate as much useful data as we can as we go, and to keep our patients safe. Our challenge now is to really relaunch our main research programs that we're doing, as well as to ensure that our service remains as excellent as possible and get our patients back into the clinic. So I'll acknowledge our team locally who've done most of this work. We're striving to improve outcomes for patients with inflammatory bowel disease. It's been a joy to work with my colleagues in dermatology and rheumatology throughout the pandemic to look at the cross-IMID approaches, because there are multiple learnings throughout. So I look forward to taking questions and having some discussion. I hope you've found that of interest.